Hey YouTube, welcome to another edition with Nursing Dynamics. I am Dr. Pace Newburn and this is Dr. Ray. And today we're actually going to do something a little bit different for our channel. We are going to talk about basically consider these things, or if you want to be an FNP or FNP 101, however you want to look at it. We don't have a formal title yet. We'll have it by the time the video is posted though. So I'm going to ask Dr. Ray some questions. Dr. Ray is a FNP. And gonna ask her some questions to help give you all insight as to whether this career path, once you finish your BSN, is for you. But before we start, we're gonna have Dr. Ray kind of tell us a little bit about herself, education-wise, in terms of, how she came to this. And then we will go into the 4 questions that I have.
Thank you so much, Dr. Pace. So, like Dr. Pace said, I am a family nurse practitioner. Education-wise, I finished my Bachelor's of Science of Nursing degree in 2006. I started practicing as an RN in 2007, early 2007. I passed my FNP boards in August of 2014. So I've been practicing since then. And I earned my doctoral of my DNP in December of 2017. That's my educational background. In terms of practice, I have practiced as a family nurse practitioner in a family setting, seeing patients from birth until elderly. I've also done addiction medicine. I've also done skilled nursing facilities, as well as long-term care settings.
Okay. So when it comes to education, we know your educational background, but what is it that you think would really prepare registered nurses to, educational wise, to really set the tone for being a good FNP or nurse practitioner in general, but we're talking about FNP today?
That's an excellent question. And also, I forgot to mention, I'm also a nurse educator. I actually teach family nurse practitioner students as well, and have been doing so for the last several years. So some of the things that would make you a good NP in terms of education, first of all, go to a good undergraduate program. And what does a good program mean? One that has rigor, one that has high standards. And I want by high standards, just because you think it's hard doesn't mean they have high standards. One that has high standards, and make sure you have an excellent grasp on anatomy and physiology and pathophysiology. If you don't, just don't even sign up for NP school. Just don't even do it. You're going to kill somebody, seriously. And you want to have a good grasp of pharmacology as well. In terms of practice as a nurse, everyone thinks going to the ICU. The ICU is not going to help you here. Not in the role of an FNP. Talking about CRNA, you talk about acute care NP, we talking about a whole different story. We're not talking about a midwife. We're not talking about that. We're talking about FNP, and I would even venture to say an adult nurse practitioner, and I would even venture to say a peds nurse practitioner. Your ICU experience is not going to help you here. In fact, it will just confuse you more. Some of the best experience as a nurse for FNP, if this is something you're considering doing, I would say would be in the ER. That would actually be your best experience, because as an FNP, primarily, you're going to be working within the community settings. Yes, there are positions where you are outside the community setting, but for one, your training is going to be more so community health based, number one. And number two, most positions for FNPs are in like clinics and outpatient settings. Yes, there are some inpatient settings. As an FNP, I could work in the ED if I so choose. I choose not, but I could. It's in my state anyway. So I mean, per my board of nursing, that's within my scope of practice where I practice, okay? That may look different in other states. That said, your ER, because not only do you see emergencies in the ED, but a lot of people come to the ED for routine primary healthcare because for whatever reason, they don't get it outpatient. Maybe they couldn't get an appointment with their primary care provider. Maybe they don't have one. Maybe they are uninsured or underinsured, or just pick a reason, their medication ran out and they just forgot about it, So a lot of visits in the ED aren't actually emergencies. I would venture to say most of the visits that come into the emergency department aren't real emergencies. Some are, of course, but the majority of them are not. And that's why you hear people say, oh my gosh, I waited 6 hours. It's because it wasn't a true emergency. Also, the ED is excellent because in the community setting, and also as an FNP can work in urgent care, et cetera, but I can do another video on another day about all the different settings that you can work in per the states where I practice, okay? Because those are the ones that I can speak to, and I'm licensed in several states. That said, you don't always see emergencies in the ED, so you get a lot of primary care visits in the ED. For pediatric and for adults. So that's excellent. That will help with your training. You'll get to see a lot of the medications people are bringing from the outside into the emergency department, as well as when you're working in the community, maybe urgent care or family practice or primary care, whatever have you. People come in emergent situations all the time. So you get to see how those things present. For example, oftentimes, heart attacks don't present the same in women as they do in men, particularly African-American women. A lot of times it presents as something you may think is indigestion, and the woman is having a full-blown heart attack. So, and I've seen that, and I was unfortunate to have saw that in my clinical rotation. So, understanding how things present is huge, because if that woman would have came in and I just gave her a prescription for a PPI thinking that, oh, she just has GERD, she's gonna go home and drop dead. So this is why I say it's very important to have a strong foundation, okay? So definitely your ICU experience is not gonna help you because we're not doing drips, you're not ordering Levophed, you're not, you're not doing any sort of ICU type procedures. We're not monitoring arterial lines, not in this role, not in this role. You wanna do that, that's fine, that's a different role. So your ICU experience, I know, people look up to the ICU nurses, but here, no, we won't do that here. So the ED, possibly an outpatient setting, may be useful. If you did work in a primary care provider office of some sort or at a community health center, that will actually help you more. But the ED, I would say, would be number one because you see all sorts of things rotate through there. And as an FNP, a lot of those things you're going to be able to treat and or manage and diagnose, etc. That's where I will start. And also education-wise, for your FNP program, you need to vet your program. Make sure, first and foremost, don't go to a program that's not going to find you a preceptor. I can't count how many calls and emails I get, and I don't know ways people find my number. Apparently, my information is out there, and I get so many calls and emails. Dr. Ray, can you precept me? I don't have a preceptor. What school you go to? I go to XYZ school. Well, why is school not finding you a preceptor? And I get it, preceptors are hard to find. But for the amount of money that you all are paying, they need to be finding you qualified preceptors because they're taking your money, but they're not providing you a full range of service. That's like if you go to the dealer and the dealer sells you tires for your vehicle, but they don't put air in it. They say you go to the gas station down street to get air. While I'm buying tires, you mean don't come with air? So you're paying for FNP program that doesn't come with preceptors, and that is crucial. And you need good, strong preceptors with several years of experience. Don't go to someone that's a preceptor and they only been a FNP for a year or two. Physicians, excellent preceptors, usually, assuming that your personalities mesh, their knowledge base is unmatched. So I was fortunate enough to be trained by an intensivist for my adult health portion. Excellent, excellent, excellent training. So I would highly recommend that. So if your school does not provide with a preceptor, find another school, because what's going to happen is you're going to get desperate. You're going to end up going with any old body, and you may or may not have a good experience. And at the end of the day, keep in mind as an FNP, you have a higher level of responsibility to the patients than you do as an RN, as if that's not enough. You have more liability. So understanding that you have a greater risk of harm to someone when you don't know what you're doing. You'll be prescribing and diagnosing. I've seen people misdiagnose. And granted, of course, this could happen with physicians or anyone else too, but we're not talking about that. We're talking about this. So understand that you'll be doing yourself, your license, a disservice. And oftentimes when you lose your NP license, the RN license go with it.
Oh, I
So
didn't know
keep
that.
that in mind. Yes, because often because they will deem you as not being safe. So they're going to assume your competency is at question, and they're not going to just take your NP license. More often than not, the cases that I have seen, it all goes. So keep that in mind. And I'm not saying to scare anyone. I'm just saying it because it's true. I mean, that's what it is. It's true. So you need to make sure that the program you go to is solid, is reputable, is accredited, and has a good reputation. And not just with a few people that you know. You need to really look into the program. I'm not talking about you because you just asked your friend or your friend went there. I mean, you need to do your due diligence on these programs, see who's teaching in the programs, and faculty can turn over, but for the most part, you want to make sure that they are qualified faculty that still practice. You do not want faculty in the FNP role that are not practicing, because they're going to have outdated information. If they are not currently practicing, and I'm not talking about they got their name on a PRN somewhere that they never go to. No, I mean actively practicing at minimum 8 hours a week, so that they can keep up with the current guidelines and things of that nature and apply it to real world settings. Because anybody can read a guideline off a paper, but how do you apply that with a patient that has multiple comorbidities and a lot of issues? So definitely vet your programs, interview the faculty, ask them what kind of nurse practice, because sometimes we have other nurse practitioners in the program that aren't necessarily FNP. So like for my women's health, my didactic educator, she was a midwife. And for my women's health rotation, I was with a nurse midwife. So they weren't FNPs, but they were more than qualified to teach that portion of the program, because that was their specialty. So interview them about how long they've been in practice, where they practice. If they tell you they've had their license for 19 years, but haven't practiced in 18 years, immediately no. Immediately no. Take somebody else, because you have to be caring. And the only way to be a good nurse practitioner, and I don't care what kind of nurse practitioner you are, you have to stay in clinical practice, because you have to constantly sharpen your toolbox. And the way you get better as an NP is with encounters. Anybody can read, but you have to have encounters so that you can apply that to how that particular patient is having issues along with all their other comorbidities. So you need encounters. Case studies are just not going to cut it, not in this role. And yes, it's good to read, but in this role, you need encounters to keep your skill set sharp.
So that's great. I want to piggyback off of this though, because being that you are practicing FNP, and being that you mentioned that this extensive education that you feel that FNPs should have, and they should vet their programs and on and on and on, being that you're currently an educator for FNP students, what do you see in practice, or when it comes to school now, or even current or new FNPs now, that you feel like we're in trouble? Nurse practitioners are in trouble, or FNPs are in trouble, because I went to school based on this set of standards as an example, and based on what I teach, and based on the educational system, and based on what I am seeing put out here in the workforce, this is not aligning based off of whatever. Or, we often talk about watered down profession or watered down programs. We can go into direct entry programs and on and on and on. And so kind of, can you touch on that for a little bit?
Sure. So one of the things this could be a rabbit hole, but I'm not going to go down an entire rabbit hole. Let's start out with number one, the direct entry programs. Most of them, from what I've seen, are trash. If you don't have, I mean, that's just what it is. Most of them, you have a few, and it's a very few that are good. Johns Hopkins, for instance, you go to Hopkins, you're getting a good education, period. But unless you are at an elite school like that, 9.999 times out of 10 is trash. Okay. Because you don't have those foundation assessment skills that you would have developed as a nurse. So now you're going into advanced practice where it's just that it's advanced. You're going to advance something that you really never had to begin with. Those few hours you doing clinical in a BSN program is nothing. I describe it this way: a direct entry program to being a nurse practitioner is like getting your license today, and instead of driving like a Honda Civic or something, you go straight to an 18-wheeler tractor trailer. Make it make sense. You finna kill somebody on the road because you can't park a Honda Civic. But now somebody giving you 18 wheels? Come on now. It doesn't make sense, but people don't think of it that way. People, it's a microwave generation. People want what they want. They want it good, they want it fast, and they want it cheap. But like they say, you can only have it two ways. So people want everything good, fast, and cheap. And that's what they're doing to education across the board. But right now we're talking about nurse practitioner education, and there's no exception here. So definitely most of the direct entry programs are trash. I recommend at least 5 years of clinical experience as a nurse, as a registered nurse, prior to even applying for nurse practitioner school. Because keep in mind, the stakes are higher. When you screw up, is when it all starts coming down, it's coming down harder, because not only are they going to take your NP certification, they're going to come for your RN license too. So all those years of school and everything, it's like, I heard somebody say, did you use the bathroom lately? You hear that flush? Yeah, because that's your license going right down the toilet. So you might as well go in there and flush it next time you go in there. So keep that in mind. Also, another thing that I see is a lot of these programs are under preparing students. By that, I mean, they don't require enough clinical hours. And keep this in mind, clinical hours and encounters are two different things. If you're in a clinical setting for 12 hours and you only saw one patient, the other 11 hours are about as good as toilet paper. It's completely useless because, but see, you'll get credit for being in clinical 12 hours, but you only saw one patient. So again, back to what I said previously, the only way to sharpen your toolbox as an NP, or I should say the primary way, is through encounters. You only had one patient, one encounter. It was just a blood pressure medication refill. Right. So you go ahead and give them another 30 days of metoprolol, say follow with your primary care, or come back, or whatever it is you're doing. You've done nothing. You've done nothing. I mean, heck, you could have automated that part. You could have got the nurse to call that in. So, you know, and I see this happening all the time. It's really a disservice, but students probably don't realize they're being disserviced, or they don't care, or whatever that situation looks like. But if you're finding that's the case, you need to find another clinical site. And I know clinical sites are hard to find, but again, the stakes are higher. So again, you go ahead and you're going to sit in that 18-wheeler and you're going to drive, and you barely got control of a Honda Civic. Good luck with that. Another thing with these programs are, and again, education across the board, but now we're talking about nurse practitioner programs, you know, they'll charge you all this money and you're getting a subpar education. It should be heavily focused on, you know, patient management, disease management. Patients are living longer. You're going to see a lot of elderly patients. I think a lot of them need to focus in on geriatrics more than what they do. But again, that goes into the component of, you know, clinical encounters, clinical variety, and things of that nature. But I would say that's the primary thing that I see, and not just counting hours, but counting encounters as well. And also having that bond with your preceptor so that you can learn from them. I've seen students get fired from their preceptorship because they get there and they're not cutting it. The preceptor say they're too incompetent and I don't want to work with them. So now, if you can't find another preceptor ASAP, now you're going to fail the class. And I've seen that happen a lot too. And it's usually, you know, the nurses with the biggest egos are usually the ones that go first because you're not coachable. Again, your ICU experience pumping up your chest because you were ICU nurse, nobody care here. Nobody cares. Okay. They don't. I mean, even if you're ED, nobody cares because it's a different scope of practice. So nobody cares. So it's, you know, you have to be able to come to the table humble and understanding that it's going to be a learning curve and that you don't know everything. And just like when you were a new nurse, you didn't know everything. So years down the road, you realize just how much you didn't know. You'll have a similar learning curve here.
Okay. All right, very good. So we already alluded to, the second question is, who do you see? We've already kind of alluded to what the gamut of, or the spectrum of a FNP is, but specifically in your practice today, as of today's date, what patient population are you seeing?
As of today's date, I'm currently seeing patients in a skilled nursing facility and um, in a long-term care facility. And that encompasses a lot of different things, but that's what I'm doing at the moment.
Okay, so and then for those who may not know, we're talking about maybe people who are in nursing school currently, getting maybe their bachelor's and hadn't thought that far out. So for the novice, so for someone who's just inexperienced, there's a no. So we know what LTC is, long-term care, and skilled nursing facility, SNF. But what kind of disease processes are you managing? Because that is what you do, is manage their disease processes. I don't think a lot of people understand. This is not, you are beyond the point of, here's a list of orders to do. You are the one who's writing the order.
Yeah.
And the people and the LPNs in the skilled facility or LTC is executing those said orders. So what kind of disease processes are you seeing?
In terms of disease processes, like I stated before, people are getting sicker.
Mhm.
Where I work is a primarily underserved population. So my patients are very sick. It would probably be easy for me to say what disease processes I don't see.
Okay.
Obviously, we don't do any OBGYN, that kind of thing, but everything from your hypertension, diabetes, asthma, seizures, wounds, acute infections, UTIs, seizure disorder, post-surgical, because we also have rehab there. I have dialysis patients. Dialysis patients are always super sick. They are always super sick. We have a whole unit there with dialysis patients. So anyone who has been in healthcare and had dialysis patients, you already know their list of problems is always long. Very seldom do you see a dialysis patient and their only problem is renal failure. I don't think I've ever seen one, but if you find one, great, and that's probably the only one. So just across the gamut, no one there is like pregnant or anything, so we don't have a lot of that, but we do have GYN issues that come up too every so often, and everyone there is an elderly, or everyone there happens to be an adult, but everyone there is not elderly. So sometimes we get women who are menopausal or postmenopausal, or may have vaginal bleeds. We actually had one there not too long ago to find out she had cancer, and that's why she was bleeding down there. Yeah, she's being worked up for ovarian cancer. We get that too. We have patients with different types of cancers. I have one now who we are trying to talk with the patient's family to consider hospice, and that's a whole nother story. Because he has cancer and we're thinking that it's spreading, and he has other issues. His wounds aren't healing. He's getting sicker and sicker. He looks like a ghost. He's very pale. It's just a mess. We have a dementia unit, a dementia/psych unit. So everyone up here is just totally gone for whatever reason. Everything from bipolar, schizophrenia, schizoaffective, different types of dementia, anoxic brain injury, just different types of neurodegenerative disorders. Ortho, we get a lot of ortho there because some of the people are elderly and they fall and they break things. So managing that, rheumatoid arthritis, other autoimmune disorders. Down syndrome, I have a patient with Down syndrome. She's highly functional. I mean, that's why I said the list of what we don't see is probably shorter than the list that we do see. So it pretty much runs the gamut. I mean, now somebody say their water broke, I'm done. I'm calling you, doc. I'm like, look, I don't do that, but it's pretty much everything. Breast cancer, I have a patient there that has a really aggressive form of breast cancer, and her breasts are very hard. And it's too much of a long story of why they're not doing the mastectomy, but she's basically gonna, we think she's gonna probably expire soon because the cancer is taking over. Her breast, it feels like cement is in there. And it sits on her chest and bleeds, and it's just, it's bad. I actually had a patient like that before many years ago, but this patient, and she's young, she's in her early 40s. I think she's 41 or 42. So Yeah, we see the gamut, and you have to understand anatomy and physiology, and
Mhm.
you have to understand pathology in order to manage these patients. And you have to have a strong understanding of pharmacology, renal dose, how to dose for, different issues. Like I said, we have a whole dialysis unit, so I have to always know how to renal dose my medications, collaboration with pharmacy. You have to know how to critically think. And to do something like this with no nursing experience, you are shooting yourself and your patients in the foot. You're gonna crash and burn. You're gonna crash and burn. I hate to say it, but it's true. And these patients aren't in the community right now, but they came from the community.
Right.
So even though this is an inpatient facility, where do you think the patients come from? They didn't come from Mars. They came from the community. So even as an FNP in a community setting, this would be one of your patients. It just so happened that they're at this facility it was just one extra thing that they just couldn't handle on the outside. So now they're inpatient. Like one patient, she sustained a sternal chest fracture. So, it's causing her to breathe more shallow, that she's with pneumonia and this, that, and the third. So now she's in the facility, but literally last week she was in the community and she has multiple comorbidities that you would have had to manage in the community. Or she may have even, and she came in the ER, she went to the ED. And then was admitted to the hospital, and then she got shipped to us. So again, that's why I said ED nurse, a strong ED nurse, I think would be a good foundational education for a role such as this or similar.
Okay. You may have mentioned this throughout today's discussion, but before deciding on being an FNP, so I'm like, okay, which do I want to really do this? What do know this? What is your know this? Before, what is that one thing you can say that is not taught in nurse or in the in practitioner school? It's nothing that you will get in practitioner school. And that's true with any program. There's no way to teach everything. But before you decide to become an FNP, know this. What is that?
Ooh, that's a good one. I think, all right, let me try to stick it to like 2, no more than 3. Number 1, if you are burned out as a nurse, don't do it.
That's a good one.
Because one thing I can bet my bottom dollar on, you're going to be burned out as an FNP. Because it's the same drama, it's just a different title is really what it is. It's a different scope of practice. But if you think you burnt out, you're just going to get more of the same, number 1. But nursing school is not going to teach that because they have a degree to tell you, right? So they're not going to tell you that in undergrad either. They're not going to tell you how all the nurses in the hospital are burnt out, losing their minds. They're not going to tell you that. Most of them won't. Number 2, number 1, don't do it because if you're burnt out with nursing, just figure out something else to do. Because I'm telling you, you're going to spend all this time, money, and effort, and you're going to come to this role, you're going to be burnt out. Number 2, I would say, have understanding for the business side of healthcare. I know a lot of nurses don't understand that. And I'm not saying you have to be like a CEO level or CFO, but you need a basic understanding because one of the primary roles of the nurse practitioner, of course, to take care of patients, but is to generate revenue. Because I tell you right now, you can take all the patients you want. If you're not making whoever you're working with some money, you're not going to be there long. You're not. That's just the end up because unless you're working under some sort of grant, or maybe sometimes an occupational health, their model is different. But for the vast majority of jobs as a APRN, it doesn't matter if you're a CRNA or whatever, the vast majority of positions are going to have to generate revenue. And if you're not generating a certain amount of money, not only will there not be money to pay you, but also the overhead and to run the business. And you need to have an understanding of that. Because if you don't, not only are you gonna have a hard time with employers, but you're gonna have a hard time understanding why things are the way that they are. So without going too much into detail, have a basic understanding of that. And that's in any APRN role. And there's only a handful of roles where you're not doing some sort of billing. And those are the minority of positions. So know that. And I would also say, know your why. Like Dr. Pace always says, know your why you're doing it, and make sure you're doing it for the right reasons. And also another thing people don't realize is people think that they're going to get this huge raise when they become a nurse practitioner, and it's not necessarily so. I always say, and I will die on this hill, you don't get what you deserve, you get what you negotiate. So keep that in mind. It may be a pay raise for some, but when you consider the amount of liability and what you have to do, oftentimes it's not worth it. And a lot of times nurses at the bedside can make significantly more money if you're looking at a dollar for dollar. It's a different role, however. It's a totally different role. And personally, I like the role, and I like the challenge of it. I like to critically think. I like the patients that with the multiple comorbidities, and I can really just kind of dive in and kind of figure things out like that. But that's what I like to do. Some people don't like to think that hard. And if you know that you're not that kind of person, then you might want to consider something else.
That actually takes us to our last question. Do not become an FNP if
Okay, do not become an FNP. Again, if you're burnt out at the bedside and you're just looking for a way out, what I always recommend to my students as well as my mentees, try something outpatient. Anything outpatient as a nurse, patient first, outpatient surgery center, doctor's office, try something outpatient and you will be amazed at just how much better you feel, just not being in that inpatient acute hospital setting. And you may save yourself a whole lot of headache. And I know a lot of people went back to school to be a nurse practitioner, not necessarily FNP, but nurse practitioner of some, or APRN, I should say, of some sort, and they don't even practice because they got into a real they don't like it. And off the top of my head, I can think of 10, just off the top of my head. It's plenty of people that do it. They go, they get their MSN, and you know, they go through the training and everything, and they either don't sit for boards, or they sit for boards and they practice for maybe a year or so, and they get completely chewed out and they don't like it. And I just so happen to practice in an independent state, but a lot of the states still don't have full practice authority, meaning that NPs are still tied to physicians to some degree or another, depending on the state. And a lot of times that is a point of tension for people because they are butting heads. So I would definitely say, if the number one thing I would say is, if you're just burnt out from bedside, which I totally get because so was I, and you're thinking about doing something else, that's fine. But if that is your primary and or your only reason for pursuing an APRN career, regardless of what kind of APRN you want to be, you're going to just be miserable in a different role. I can just about promise you that.
Okay, so that concludes our consider, if you want to be an FNP, and these are the things to consider. I'm gonna let you close us out. However, what final remarks do you have?
I think that's the main thing. The main thing I would definitely drive home is to make sure you have multiple years of experience as a practicing nurse. I suggest the ED, but whatever it is, even if it is the ICU, you still need experience. Definitely that, and definitely vet your programs. And that I would say those are the top two things. Definitely vet your programs. And if you're burnt out, try something else first before you spend the time, the money, energy, and the effort and the stress to go through APRN program to just find out later that you don't like it.
All right, close us out.
And in closing, we want to thank you for joining us. We have a list of nursing school essentials, as well as some personal use items in our storefront link at the top. So you can go there. These are some products for nursing school we have vetted to study for the NCLEX, your TEAS exams, your entrance exams, as well as anatomy, physiology, patho, different book recommendations. We have taken the time to vet, and we think that these are very good resources for you. And we also have some personal care, things like skincare and things like that, if you're interested in those sort of things. Thank you so much for tuning in. Until next time. Bye.
Bye.